Hey everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today our guest is Audrey Long and she's going to discuss 3 shoulder cases that she misclassified day 1 or that did not do as well as they could have on the follow-up visit. Audrey is a physical therapist with over 30 years of clinical experience. She completed her diploma program in New Zealand at 𝗏𝗏𝐚𝐬𝐭's clinic in 1993, and she was promoted to teaching faculty in 1997. I hope you enjoyed the show. 𝗏𝗏𝗜𝗡 podcast is only possible with the support of the forward-looking and innovative company Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi Audrey, welcome to 𝗏𝗏𝗜𝗡. How are you today?
Doing fine, thank you.
Awesome. So let's get started and tell us a little bit about yourself, your background, your career, and how did you get to where you are right now?
I'm a primarily physical therapist, still doing after more than 30 years clinical work, and I teach with the McKenzie Institute, so I teach the MDT courses, and I've taught a bit in the US, but mostly in Canada, and I've had a chance to do a little bit of clinical research as well, so that's kind of kept some variety in my career over the years between bits of research, teaching, and work in the clinic.
Awesome. So I know you prepare a few cases to share with us, some shoulder cases. Do you want to get started sharing the first one?
Sure. As I was skimming over reviewing these this morning, I realized all 3 cases are males between the age of 40 and 60 who have sedentary jobs and have right shoulder pain. So they all have that in common. So,
Interesting.
And then as I go through them, I'll just pick up the highlights from their subjective. I won't go through the whole form, but just so the audience knows, I did ask more detailed questions than perhaps what I'll present here. So the first case is Jay, and he's 62 with right shoulder pain. And he's been in for physio before with me over the years in the past with back and hip pain and then an Achilles problem. So he kind of feels comfortable, and he's one of these people, they jump in and they start telling the history. So I'm circling things on the form, and he's repeatedly pointing to his anterolateral shoulder, just quite locally there. And then his onset had been about a month before he saw me, and he'd spent a weekend doing a lot of trimming of hedges and bushes, trees in his yard, as well as cleaning all their exterior windows in their house. So that's what he attributed this shoulder pain to. And so his chief complaints, where he just kept talking about, he's having trouble using that arm to reach and lift with things. So I think in that quick description of the patient gives, it's easy to think that this is a shoulder problem, and many clinicians might just jump in and with the exam from there. But the nice thing with our MDT form is you can have it in front of you and you look up and what haven't I asked him? Well, I haven't asked him if there's pain anywhere else. So that's when it starts to look like, this might not just be just a shoulder problem. So he reports, I said, does it ever radiate down your arm anywhere? Well, sometimes I have triceps pain that goes into my medial elbow. So there's an associated radiation. And then asking about his neck. I know I've treated his lower back, but asking about his neck. I've always had a stiff neck. I sit at a computer. I said, yeah, I know you do, Jay. So he has a stiff neck, but in his mind, it's not a neck problem, and he hasn't made a connection between that and his shoulder. So I asked him about sitting, thinking about some of those clues we get from the Xbox study, and he said his shoulder can ache, but he attributes it to, or his elbow as well, to leaning on the armrest. So if he leans on the elbow, he'll get some shoulder pain, but This fella's about 6'2", I think he's tall. So knowing if he's got his arm down on an armrest, he probably is in a slumped position. So then that starts the pain distribution and bringing in that clue with the sitting makes me realize I should have to examine neck and shoulder. And he's been trying anti-inflammatories, and of course, as they often do, they go to the doctor and get an ultrasound, and he does have a partial thickness tear. So he's quite focused on the shoulder as well. Yeah, so as we carry on from there into his physical exam. So I know I probably have to clear his spine. And in these cases, we really want the patient to feel we are engaged with their primary complaint. So I make sure that the patient knows I'm always focused on the shoulder. So I start with the shoulder exam. I frequently go back to key tests of the shoulder, even if I'm going to look at their spine. And this might sort of be one of the first tips I'd like to give the audience is I do hear therapists going into long explanations about why they want to look at the patient's shoulder, because the idea is that, well, we should get consent. The patients come in for their shoulder, and now we're going to look at their neck and spine. And I keep it really simple. I just say to the patient, I always like to look at the area above and below the most painful area, because often there are things nearby that are contributing to your pain. So let's just make sure I don't miss anything there. Does that make sense, Mariana?
Yeah, and I think that makes a lot of sense, and saying those things just super quickly and superficial right in the beginning, because sometimes we spend a lot of time explaining all of that. And then in the end, it's not connected with the neck, and you just spend a lot of time explaining something that's not even relevant for that case. So I think that just giving that short explanation that allows you to kind of go and assess a little bit the neck and elbow, shoulder, whatever it is. And then if you see a relation, then you can go deeper in that after, right?
Right. So the descriptions are trying to explain referred pain or radicular symptoms or whatever. That can come later once you know that's what you're dealing with. So this keeps it simple. And I say, I just want to take a quick look up here and see if there's a lot of connections between the shoulder and the neck. So it might be that there's something that's connected with your problem. And then I usually can get through that bit of having them willing for me to look at their neck quite easily. And I do hear therapists sometimes struggle with that. So maybe that tip will help. So to stay focused on the shoulder, I'm going to start with his shoulder exam, jump to his neck a bit, but keep coming back to the shoulder. And this was a fairly fun assessment to do, just for the audience's background. Not only have I treated this fella before, but he lives on my block. So we've been on the same street for, 25, 30 years. And he, I've treated his parents, so I know his elderly parents. So we definitely have a social circle that interconnects at times with barbecues and whatnot. So he's chatting away, and I'm, trying to keep him on track with his shoulder. So we start with postural correction. So he had no pain sitting there in the shoulder. And so, of course, no change with postural correction. And then his range of motion had an interesting pattern in that he had full abduction with a very minor painful arc, nothing much at all. The painful arc was more apparent in flexion, and there was a minor loss that last 5 or 10 degrees of flexion. He was very painful, though, with hand behind back, with a painful arc, and he could push himself to nearly full range. But when he did horizontal ADD across his body, he really was unhappy with that. So that was really painful, and he wasn't willing. I put a moderate loss of motion for that. So that was going to be our key test. That horizontal adduction was going to be one of them, behind the back and forward flexion. So I picked those 3 because, surprisingly, with all his concern about reaching and lifting, his manual muscle tests were all full strength and pain-free. So that was nice. All right. So then I said, all right, so we've got these findings in your shoulder. You've told me about that stiff neck. Let's take a look up there. And this was one of those cases that your listeners might wonder why I'm presenting it, because it starts out so simple. few retractions, few extensions, and that his shoulder movements became less painful. So we would do 2 or 3 sets, recheck his shoulder movements, and they were doing better, especially when I moved down. There was a little bit of change with retraction, extension, but as soon as I went to thoracic extension, he had quite a big improvement in his ability to easily get to his end range with hand behind back, and also that horizontal adduction. And because he's been treated by me before, he caught on really quickly to this retest. So every time we did some spine stuff, I didn't even have to ask him to move his shoulder. He just started doing his adduction to see if it was different. So as he was standing there, I said, "So is your shoulder maybe feeling better or definitely feeling?" He says, "Oh, definitely." And the nice thing with this fella is I didn't have to do a lot of education on that, because when I treated his back some years ago, he had pain that referred into his hip, and it's centralized. So I just made reference to, this is similar to that hip pain that would centralize to your back, this shoulder pain might centralize to your neck. And is that enough of an improvement? Are you happy to go home just doing that thoracic extension? So he was happy because it felt better. Now, this is where we get into trouble being too with our patients. So we got chatting. I asked about his son, and then he said, "Oh, and did you hear about that incident at the house at the end of the block?" I said, "No, what happened there?" And so we get chatting, because it was a very quick assessment, so I had spare time. We book an hour, and I think we got through this all in about 40 minutes. So we're chatting, and yeah, I think it's all pretty clear, and he heads home to do some thoracic extension. And that was, I can't remember if that was a Wednesday or Thursday, but he comes back for a visit too after the weekend, so 3 or 4 days later. "Hi, Jay, how are you doing?" "Oh, Audrey, those exercises were terrible." What? It was such an easy case, you're expecting visit 2, a little more of a slam dunk. So I usually start with my, routine about, we did talk about his posture on day 1. So I said, "Were you, careful how you were sitting at the laptop, your computer?" "Oh, yes." "How often?" And he said, "Well, the first 2 days, Audrey, I did it every 2 hours, just like I used to do with my back. And by the second day, it was so sore, I had to stop." I'm going, wow, thoracic extension bothered him that much? So MDT brain, I'm thinking, did I miss a lateral component? There was nothing for spine in his range of motion that made me think that we'd have to go lateral, but maybe I missed something there. So I check for their posture compliance, I check for exercise compliance, and then I like to say, "Well, show me your exercise." So he stands up to show me repeated horizontal adduction of his shoulder.
Oh my goodness.
So he went home
No.
and kept doing adduction of his shoulder.
Oh.
And I hope most of my audience can identify with patients coming back not doing the exercise you sent them home with. But I think for young therapists, I was thinking of this case because it wasn't long ago. I was a new grad working in our clinic, and she was struggling. I could hear her struggling with a patient, an elderly patient. And as she left, I asked her some question, and she said, "Oh, well, that was my grandmother." I thought, "Oh my gosh, you brought your grandmother in for treatment." And, my experience over the years is that family, close friends, and maybe this fellow was a little bit too close of a friend, although I didn't think so. He's a good acquaintance for sure. But even coworkers are bad, like treating a receptionist or another physio, because if you're running behind, they'll say, "Oh, you're so busy today, Audrey. It's okay. I'll see you Thursday instead." And the follow-ups never happen with coworkers. So it's a real challenge. So in our clinic, we have a diplomat in our clinic. Poor Mary Lee, she's treated 3 or 4 of my family members, and I've treated some of her family members, because we're both aware of how hard it is to be really objective and whatever. So I think there was too much with Jay social chitter chatter towards the end of his visit that I wasn't really clear what he was supposed to work on at home. And it seems so clear to us, right? That his shoulder got better after he did thoracic extension. So that was a a big oops, and I think a highlight of the importance. I really think visit 2 is almost more important than the first day. I really need some time there to make sure things were done right.
And I think that's the danger of treating people that you really know, because you get comfortable and then you skip those steps that you always do every visit, that you make sure that you educate the patient, that they understand and give their homework. And then like I usually ask, so what are you going to do? How many times? Just make sure that they understood, because for us, sometimes it's so obvious and clear, but not for the patient. So he was doing a lot of tests on his shoulder, so he probably assumed that was his exercise, and that was never something that crossed your mind. So I feel like, as we said, sometimes we're going to cut corners with those type of patients and not be super strict with our structure, and we change the structure in our minds, and then we can miss something. And
Yeah,
then that.
and most patients, I'll send them home with either a picture of the exercise or a picture on their own telephone. So for a reminder, I didn't do that with this fella because as a clinician, to me, it looks so straightforward. So there we are with an oops by Audrey on that one.
Well, but I think it's good to share, so we alert people to not forget about that, because that's like a honest mistake. It just can pass right by us, and we don't even realize until next visit they come and are worse.
A quick test of that you can often do just as they're leaving is to say to them, so just show me one or two more reps of the exercise you're going to do at home.
Yeah.
Right. And
Yeah.
if I had done that one question before he left, I might have realized what had happened. So, and it's funny, he felt a little silly too, because in hindsight, he realized it. I said, oh, I think we wanted to do this one. Let's review this one. He said, oh yeah. So.
Yeah. And then after that, did he get better?
Oh yeah, really fast. So that was, 3 or 4 visits, and he was fully resolved. Absolutely. So
Awesome.
very easy thoracic derangement, reproducing shoulder pain with that one. Yeah. So any questions about that, or would you like me to move on to the second case?
I think we can move on to the second case.
So the second fella is a little bit younger. He's 40, and although he's fairly sedentary, he does go to the gym and work out a little bit. And this is a study I'd sort of like to connect it to the 𝐓𝐸𝐴𝐵 study, because there's so much good information in that 𝐓𝐸𝐴𝐵 study, and it maybe helped me or maybe led me astray in this case. I'm not sure. But he again pointed to superior lateral shoulder, but he was also quicker than the last patient to volunteer that it goes around. So he brought his hand around to the back over his trap and scapula, that there were some symptoms back there as well. So from that, I was a little more suspicious of neck involvement. But again, his better and worse section, he wasn't worse sitting. He wasn't worse turning his neck. He wasn't worse bending. So he didn't give those cervical clues. So again, it could be perhaps easy for a new grad to jump in and just treat this fellow's shoulder, because his pains were getting dressed, reaching, rolling onto that side, reaching overhead. It sounded derangement-like, because he said it was very variable with chores and lifting, that sometimes it hurt a lot and sometimes it only hurt a little bit. The other only interesting thing about him was he is a type 1 diabetic, and I've learned over the years that they're a bit more prone to a frozen shoulder. So in terms of differential diagnosis, is it his neck, is it his shoulder, and then is it something in that category to consider? All right. And then range of motion. So he had, again, not bad range of motion like Jay did. He could get full range of motion with everything except extension and external rotation were both minimal losses with end range pain. And I guess if we're suspicious of his spine, his shoulder, then we would expect there wouldn't be a lot of shoulder signs, and that we would find stuff in his neck. So again, this one looked straightforward day one as spinal. When I got to checking his neck range of motion, he had that classic pattern where there's a bit of loss of cervical extension. There was some loss, minimal loss of rotation and side bend towards the painful shoulder. We did some repeated retraction, extension, and his shoulder signs all felt better. So he was happy to go home and do retraction and extension. So again, this one sounds good. And then better than the last case, he came back visit 2, definitely better, like 50% better. So we went further into range, further, add some overpressure, and oh, that feels good. So we stayed visit 2, we stayed on his spine. And then for something that looks so simple to clear up, I guess I'm not very satisfied when visit 3, they're not saying huge improvement. It's okay if it's, a bit of improvement visit 2, but something happened on the 3rd visit that he had plateaued. He hadn't had a big improvement. So again, we have our one-track mind with our MDT. Oh, I missed a lateral. So we went lateral, and I worked him really hard on this visit. We did side bend, we did rotation, we did overpressure, extension, and couldn't find something that really turned his shoulder pain off or convincingly centralized it. I've lost track now if this was visit 3 or 4, but by visit 4, he's 70 or 80% better, but we can't get that last bit. And I decided maybe I should look at his shoulder, because things weren't, that end range of his extension hadn't recovered, which is an odd movement. So can't remember which one we started first. I don't have that note here, but we ended up that day with hand behind the back with the strap. So a combination of extension, internal rotation, and really pulling. And he got that look on his face. Oh, that feels good. And that last bit of shoulder pain that wouldn't clear just abolished. And he came in for an extra visit, but he was pretty much pain-free. So what are you doing here? But convincingly, that hand behind the back had worked. So the reason I brought this up is the 𝗏𝐸 study is such a nice one, but it really suggested to us from their data that they could clearly distinguish it was neck and you could stay with the neck, or it was shoulder and you could stay with the shoulder, and that there wasn't often an overlap. And I just wonder if the 𝗏𝐸 study is I think one of 2 studies that's looked at this really nicely. I think Joe's study looked at it as well. But as we do more of these, will we discover more information? Because in the clinic, I do see people where I have to leave the neck and tackle the shoulder. And I think this is the hardest thing still for me, and I see it with other clinicians as well, is if you start with the neck, not being married to the initial diagnosis all the time, and being willing on visit 2, 3, or I think it was 4 with this guy to change gear and say, maybe I should look at his shoulder. And the opposite's true. If you decided to start at the shoulder and you hit a plateau in their progress, to go back to the spine again. So that's what we had to do with this one. And he surprised me, because I haven't seen someone who looked so clearly spine, and he was convinced it was spine because he had enough improvement. It wasn't like a patient I had to convince. And then just being curious and exploring some of his repeated movements to find that a shoulder movement turned it off that last little bit. So that I guess is a study on. A lot of initial studies come out as very promising, with some it looks like really good data in them, but until studies are replicated a few times, so we shouldn't be betting the house on them. Keep them in mind. It's good information for now, but being willing to still always listen to the patient and realize we have to switch gears sometimes, despite what one particular article might tell us.
Yeah. And so in that case, do you feel like they were 2 different arrangements? Like the neck then when you clear the neck, you're able to just see the shoulder, the rest that was left of shoulder derangement. Like, what are your thoughts?
That's what I'm tempted to say, that he did have a little bit of something going on in his shoulder. And then the only other thing I'm wondering about is this hand behind the back movement. I've seen it both help and aggravate people with a spinal problem. And, when we think of, I would like to find some research on this, but when we look at upper limb tension tests, if we go to the radial one, which is hand behind the back, but with the elbow extended, I'm just wondering if when you twist and bring that hand up behind your back, reaching, your thumb up towards a bra line or whatever, if there isn't some dural component. So when necks are aggravated by hand behind the back, is that like giving somebody with a lumbar derangement a bunch of straight leg raising to do, that could easily aggravate their derangement. So I'm not sure. I'm happy to go either way with this. Can moving the shoulder also have moved his neck at the same time in some way? I know I've seen examples where therapists have used horizontal adduction to facilitate rotation of the neck. So, with a water bottle, you can turn the head or the cap, but you could also turn the bottle from below. So they use movements from the shoulder to move the spine. So did I move his spine in some way by adding the way he did his hand behind the back? Anyway, he got better, and that's the nice thing about MDT is we don't always have to have all the answers. The patient feels better. And
I was just thinking here. So if you happen to start with the shoulder instead of the neck, and you have the nerve still irritated, you may not have the same results with the shoulder movement that you did at first that got him better. It may be like it wouldn't be true, the opposite. You know what I mean? If it's like just here thinking out of the box, if it's a nerve that's irritated, we may need to clear the derangement from spine first. So then he's able to respond with shoulder. I don't know if that's the opposite is true.
It could be. Anything's possible.
It could be.
Yeah.
Because
Yeah.
I had a conversation with 𝐏𝐸𝐿 on this last podcast that we recorded, and she was saying about how she sees in neurological problems that they respond to repeated spine movements, that they can like reduce spasticity and like all of that, which is really interesting. And she said that she does a lot of neurogliding as well, that helps. And if we put tension on the nerve and aggravates the nerve, then it's probably more spine related. And if you do the nerve and it reduces the tension on the nerve, then it's more neuro-dominated, the nervous system. I mean, I don't know if I'm doing a good job of explaining, but I was just trying to make the connections with what you just said about maybe you're moving the neck by moving the shoulder, somehow some neural connections. I'm just here brainstorming. I'm not sure, but I just thought there could be some connection there.
That's the fun thing. And over the years, I've learned to never say never and keep just all these possibilities open, because they're all potential explanations for what happens.
Yeah. Okay. I think that's a very interesting one.
Yeah. It's more about not, again, with young therapists, this is what I see, that it looks so much like spine that it would have been easy with him to stay with spine for even longer, right? And not take that 5 or 10 minutes to say, well, let me look at his shoulder a bit. And then there's the opposite, where people leave the spine too quickly, I guess, and miss not fully clearing what's in the spine. So there's a gray area there that's, difficult even for experienced clinicians to manage at times.
Yeah. And I think that's timing that's hard on like when to leave the spine and go to shoulder, because he did improve, like you said, 78% almost better just the spine. So really it's normal to just try to progress and clear the spine and do lateral. I think that's the most reasonable thing. But then to also consider the shoulder. I think that's the point.
Yeah, because I was starting to feel like I was beating him up. You're
Yeah.
trying to confirm your initial bias, and so between the overpressures and the mobilizations in the sagittal plane and the lateral, the side bends and rotations, I just all of a sudden felt like this should not be so much hard work. If the first 70% of his symptoms cleared up so easily, it should not be this hard, or usually it isn't to get that. So I just felt like it was time to pause and revisit the shoulder.
So
And
yeah,
maybe I'd
when
have
you
been
hit
wrong
a,
and had to come back to the spine again,
yeah,
but
I guess it's just think about when you hit a plateau, think about something else, other options. Awesome. Okay.
Patient number 3, local again, anterolateral right shoulder pain. He's 50. So although he's sedentary at work, he was doing a lot of workouts, working out regularly at the gym. And he tells me he hurt his shoulder doing an overhead triceps skull cruncher. So he had a very specific mechanism of injury that had happened again about a month before he came on. I've noticed what a common time frame that is. I think patients will be patient with themselves when they have an injury and give it 2 or 3 weeks, and then if it's not resolving. So he had done the common sense things. He'd taken a bit of a break, and then he'd gone back to some light exercise. So he was trying to do a very light workout, but getting frustrated that he couldn't get back to his regular workout. And he was having a lot of trouble sleeping on the shoulder. That was a big concern for him. Getting dressed, reaching for things, lifting things, and like our other patients, not saying much, no problems with turning his neck, sitting, or bending his neck. He'd had no history of neck issues. So this one's looking a little more pure shoulder. When I asked about referred or radiating pain, the only thing that made me want to clear his spine for sure is he did have some mild symptoms in the other shoulder that were there from a year ago, which had been diagnosed as a rotator cuff tear and treated as a rotator cuff tear, and had gotten quite mostly better. He'd been for treatment somewhere for that. And of course, he'd already had this shoulder and it showed partial tear. So the concern with him was more this psychosocial thing, because he was, should I get this repaired, this tear in my shoulder repaired before I get older and it completely tears? So he was asking about surgery right away. That shoulder had also, interestingly, at just the age of 20, he'd had a scope, and he wasn't really clear on what the procedure had been done. He said, oh, they just cleaned it up a bit in there. So I'm not even sure what prior procedure had been done to this shoulder exactly. But he'd managed to get back lifting weights, and he was also, it was a little bit of an anxious fellow about, what do I need surgery? And also, his father has ankylosing spondylitis and has poor movement in both shoulders. So he was also concerned about that. So he had some worries, legitimate worries with that. So he was sitting there, and the other thing that was influencing the session and the history taking is, he's a fellow that you would look at him and you would automatically suspect he goes to the gym and lifts weights. And I had a new grad physio who we'd hired at our clinic, who decided to take the day and shadow me around and watch me with patients. And this fella also, very much, it's obvious he goes to the gym. So during the history taking, these two there's some conversation between all three of us. Obviously really connecting. They both go to the gym. They don't know I lift some weights because it doesn't look like it. But anyway, anybody watching an assessment with me, if I can get them involved in the interaction so they're just not observing, it's nice to do that. So this therapist was asking some clarifying questions in the history and watching the assessment. So he had no pain sitting there throughout the history. So there's no change with postural correction, and really like full range of motion with everything except a minor loss of external rotation. And unlike the other two, who the manual muscle tests revealed nothing, this fellow was very painful and weak with a number of his tests, especially resisted external rotation. And then I sometimes ask patients, can you show me something that would hurt? And he went to do a reaching motion. He said, I think I have to have something in my hand. So I gave him a 5-pound weight. And in 𝗓𝐴𝐴tion, reaching out with 5 pounds, he could produce his pain with that. So we had resisted external rotation. Internal rotation was painful as well, but not as much. And then some painful, although he had full range of motion, he had painful arcs in flexion and abduction. So chatting with the therapist that was there, brought up tendinopathy. It was consistent with the patient's prior history of having perhaps some procedure done in there. So the therapist observing me is thinking about the tendons of the shoulder, and the patient is thinking about the tendons of the shoulder. And this is a situation of having confidence in your own skills to not let what's happening around you influence you. So I thought, well, I'm still going to do my due diligence and clear the spine a bit, because it would be nice for this young therapist to see a shoulder that improves when you do something with their neck. But that wasn't the case. We did do repeated retraction, extension over pressure, a little bit of thoracic extension, fairly quickly because he had really good range of motion, no symptoms throughout any of those. And when he stood up after, his shoulder signs were all exactly the same. So if it is a contractile dysfunction, makes sense. He had quite good range of motion with painful arcs, a lot of pain on resisted movement, that my preference would be to start with something isometric with the amount of pain he seemed to present with. So I said to the young therapist, would you like to show him that? I was taking notes. He grabbed some bands and he set him up for some isometric external rotation, which seems like, for guys that are going to the gym, that seems like such a simple exercise. It's hard for them, I think, sometimes to start with a load that is where they should be starting. So the therapist thought, well, I'm going to give him a bit more. He looked at me, can I show him some more? I said, well, what do you have in mind? And so he thought, well, besides just the isometric external rotation, that he would hold that and have him move his arms up into flexion. So his forearms are parallel in front of him and vertical. So you're holding that resisted external rotation a little bit dynamically into flexion. And it was produce, not worse, and the patient thought they could handle that. I said, would you like to give him some instructions about his loading and not worse? So I kind of let the therapist finish off the session, thinking that maybe we'd found the right load for those tendons. So I look at this now and it jumps out at me what I missed in the physical exam. So I don't know if your readers are saying, but Audrey, you didn't look at whatever. But it comes out in visit 2, the magic visit 2. So this fella, and now I was alone on visit 2. I wasn't being observed. And he came in, he was worse. And your first instinct when treating tendinopathies, they come back, you didn't get the load management right. That you should decrease the load. Maybe we shouldn't have done any of the dynamics there, or we should pick a different movement. And so I started at square one, just made sure, okay, he's worse. Why is he worse? And I always like to have, if the patient says they're worse, what in the physical exam is also worse? Because sometimes you do see a patient say they're worse, but their physical exam isn't any worse. And so his neck movements were still clear and full, but his shoulder range of motion was worse. So why did that happen? Now he couldn't fully elevate. He had a little trouble getting him behind the back, and he'd lost even more of his external rotation. And so here's what I wish I had done is, because his range of motion was so good, I don't know why. Normally I would go in and do a little overpressure right there to get them to end range. So what I missed seeing on day 1 is, and I don't know if it would have been there or not, but his loss of external rotation, it would have been nice to have a passive test, because if it was full passively, then there's less likely to be a derangement in the shoulder. Maybe contractile would be it. But if it was obstructed in external rotation, even passively, then I might have thought, oh, I got to clear a derangement first in the shoulder. So that step of clear the spine, now you're in the shoulder, make sure there's not a derangement there. So that contractile dysfunction is you have to exclude some other things, because contractile dysfunctions can mimic other things. And definitely they can mimic a derangement. So as he was demonstrating his lost external rotation, I had him relax and took him passively, and it was obstructed. I couldn't get him there even passively. I thought, didn't do the steps I normally do because I had an audience and I'm trying to engage another therapist, and missed that subtle, which is really PT 101, that's new grad, right? Active range, passive range, resisted range. And I missed the passive external rotation because it was a minor loss, and it was weak and painful on resistance. So what also confirms your initial classification is your prognosis, because we know the loading protocol for a tendon problem or contractile dysfunction takes a while. Like, they don't get better in 3 or 4 days. Well, this guy was pain-free by the 3rd visit once we got this right. So all we had to do was get his elbow on the table. So I did external rotation that way, elbows on the table, use his other hand. And it was obstructed, produced no worse, but more and more range of motion as he did it. And then we grabbed that 5-pound weight in scapation, and it didn't hurt. We had to go to an 8-pound weight before it hurt. And when he saw that, I talked about not to stop his workouts, but to sandwich, make sure he gets that external rotation as far as he can, do his workout, and then come back after. If he's sore during his workout, to pause and check that external rotation. Is there something in your workout that's undoing the good that the external rotation does? And he was rapidly able over the next couple of weeks to get back to a full workout. He did need the next visit some reassurance about really going into overpressure. So I missed a derangement in his shoulder that first day as well. And that was a fun one, thankfully, because he got better so fast once we were right on track again.
Yeah. And I think my question is, I remember you said that internal rotation was painful, but I don't know if it was restricted, because I would try to think probably to try internal rotation first, once I'm trying to figure out if there is a derangement, because external rotation, I don't feel like is as common, right? So what made you think about going to external rotation first?
Just how obstructed the passive range was. So when we did do flexion abduction, hand behind the back on him, or horizontal adduction, with just a little help from his other arm, he could take himself to full range, but he couldn't with external, and I couldn't. So in that situation, I just recognized that pattern, because I get excited when you see a pattern that you don't see very often. It's like a nice flexion responder in the lumbar spine. It's like, yes, I haven't seen one for a little while. So you're right. With most shoulders, I would have gone to extension or hand behind the back is most common. I also see quite a few who respond to horizontal adduction, which our first patient here this morning did not respond. External rotations, not very often, but it is a pattern I see periodically. And what stands out in that patient is that their external rotation is more limited than their internal, and their hand behind the back is surprisingly easy compared to their external rotation.
Mm-hmm. Okay. Yeah, it makes sense. And I think it shows how quickly you can switch to this traditional models of physical therapy. Oh, it's a rotator cuff injury, so let's start with isometrics. That's what we do. So I feel like if you're not really like sticking to the, as you said before, the assessment, the way that we do the assessment, following like the MGT rationale, I think you can get lost easily on those normal traditional ways of treating, right?
And I only have about at any one time, 15 or 20% of my caseload are workers' comp. But the cases that I take are the ones that have already had physical therapy, chiropractor, they've been to a return to work program. And as their files reviewed with the board, sometimes someone will say, well, maybe that's a case we should send to Audrey. And I would say that that's the most common one is a tendon, something that looks and sounds like a tendinopathy, and it's treated that way, and it for some reason does not respond. And so that makes it easier for me because then I go, you know what? They've either missed that it's referred from the spine or they've missed a derangement. And that's would be a very common. And then they're surprised, you know, they, oh my gosh, I've had 6 months of physio and it's now changing this fast. And most of your audience will have had the fun of experiencing that. So
Yeah, it's true, and it's kind of sad, but it happens a lot. So I think that's one of the big lessons of this case. Anything else you want to add?
No, I think that with that one, it's just, you know, don't skip the steps.
Yeah.
And that visit to the re-exam, you know, that his saying he was worse really did correlate with, like, why would you lose range of motion? Even the tendinopathies that overload and they're more painful, it might hurt them, but they usually still have their range of motion. They don't get an obstruction. It's the old word I still use.
Yeah, so that makes it clear that there is a derangement there somewhere.
Yeah.
Audrey, you ready to transition to the final questions?
Sure.
Resource of information. Anything you want to share with us that you like?
I, of course, have to like the McKenzie website under resources because, you know, it's not just a reference list there, but a nice paragraph summary and sometimes critique of a study. So that keeps me up to date. If something MDT has for some reason not come my way, I can check that reference list once in a while and keep up to date there. I also like to make sure over the years I either change the resources I'm using, because now there's a lot of different sites that give either article updates or summary updates, whether it's, you know, Pedro or Physiopedia, Key Clinical Skills with Jack Miller's another one I like to keep an eye on that's helpful. Our Canadian Physiotherapy Association, our orthopedic division, they've also got a nice, I think they call it Evidence Express page that they put out from time to time. And that comes from sort of the manual therapy group. So that's a recommendation, I think, for therapists over the years, even if you're super interested in, let's say, different types of needling and you keep up on the research there, also take a look at research in other areas once in a while. And I just never wanted to turn into one of the old white-haired physios that's out of date and not kept up. So that means just continuing to look at different resources whenever you can.
Yeah, awesome. Audrey, any advice to clinicians that are starting their careers?
I guess I'm cautious about, this is going to sound like heresy, but the term evidence-based or evidence-informed practice, because I really think we're all prone to evidence-biased practice. Because every course you go to claims that they are evidence-informed or evidence-based, and they give their reference lists. And I think we should be practicing outcome-based practice. So whatever approach you're using or evidence you're using to support your case, it should result in better outcomes. So I like, for years have used a 3-visit rule. And if there's not a definite, both subjective and objective changes by the 3rd visit, then I really have to rethink, well, what evidence was I using to treat this patient? And am I on the right track? And have to look at something different for them. I also wonder, you know, I still work in a clinic that was built many, many years ago. So we have the old-fashioned plinths with the curtains, which isn't maybe great for privacy for patients all the time because you can hear conversations that are going on around you. But the nice thing for therapists who are learning is you get to hear other therapists. So when I teach and I go to these beautiful clinics, I mean, I don't even have my own desk to work at after 30 years in the clinic. You know, we share this one very small room, which is literally standing space only. But the advantage of that is we get to interact and talk a lot. And these beautiful clinics where the therapists have their own office and their own treatment table and desk and everything in there. Lovely for privacy, but how do you learn? Because one of the credentialed therapists in our clinic that's been there for years, I love listening to her with patients. And she caught on to extremity work before I did. Here I was a McKenzie instructor teaching the spine all the time, and I was slow to catch on using it in the extremity, and she just took off with it like crazy. I think because she's way more creative than I am. So she was kind of able to take the principles, apply them, and then even tweak them a bit herself. So, and then also hearing her, sometimes we call it when you talk a patient off a ledge, when they're flared up and they're having great difficulty. So hearing how other therapists around me are explaining things, describing things, is such an advantage. So if you're a newer grad or younger therapist and there's hard walls between you and you can't hear, I think it's even more important to take. Problem is you don't get paid for that day, do you? Probably. But to have time, if there's a therapist that seems to have a really good reputation and they do really well with patients, go listen. How do they interact with the patient? Because you can't find that in a textbook. What is it that's happening in that session that works so well for that therapist? And take the time once in a while. If you can't eavesdrop like we do with the curtains, is to actually, ask permission to sit in on some suggestions, because that's been really valuable to me over the years. Even though I'm a diplomat, with credentialed therapists, they each have, in our clinic, one has more vestibular work, one's worked with a lot of hockey teams over the years. So they all have their little areas of expertise that can help me at times as well.
That's really valuable, just being able to exchange experience. And because you are really good at one specific type of patients, maybe, so then we can learn with the other's experience and just be better. So definitely that's an advantage of having someone that you can kind of listen to and exchange ideas. Yeah, for sure. And final question, what personal abilities and qualities that you feel like are important to become a successful PT?
Curiosity. I think as soon as you feel like you're in a routine or a rut and you're giving the same, advice and exercises to every patient that comes in, you're in trouble. But always feeling curious. And then if you're going to be in the career for a while, at least with patients, you have to like people. Because you're going to see, hundreds of sprained ankles, you're going to see hundreds of lumbar derangements, and some of it does get repetitive. But if you really enjoy the interaction with the patient, and I enjoy that aha moment when the patient gets it themselves and they're able to assess and reassess themselves, that is a highlight for me. And if you don't enjoy constant people interaction like that, then you'll end up in administration or research and enjoy those areas of practice.
Awesome. Well, I think that's great. And so for the ones that are listening to us and want to learn more about you or work or just contact you, how they can find you?
Probably the easiest place would be on the McKenzie website, and just go to the Canadian branch and you can find some contact information for me there. I work at Bonavista Physical Therapy in Calgary, so that would be the clinic name to look for. I'm not on a lot of social media, so the only other place you might find me is on LinkedIn.
Okay, awesome. I'm going to share those on our show notes. And Audrey, I appreciate you taking the time to share these cases with us. And I think it's just great to learn from you with your experiences. And I appreciate you being humble to come share your mistakes not really some of mistakes, but some things that it can just kind of pass by us and we don't realize. So it's just nice to bring that to our attention and share these tips with us and your experience. So I think everybody can learn from that. So I appreciate it.
I hope so. I know they weren't complicated cases necessarily, but I hope there were still some pearls there for people.
Yeah, absolutely. And I appreciate your patience with recording this podcast because we had some technical problems, but now finally I think that it's gonna be a good one.
I hope so. Okay. All right.
Thank you so much.
Oh, and thank you.